Last week, we talked about POMC, MSH cascade, and that aggressive treatments fail because they suppress symptoms, not triggers. This week, we're going deeper into why assessment matters so much. All types of pigmentation can look the same on the surface, but underneath, totally different mechanisms are at play, requiring totally different treatment approaches. What matters for us as estheticians is that we can assess pigmentation types, but we cannot diagnose it. Understanding the difference changes everything about how we treat it. Let's discuss the problem with treating pigmentation as if it is all the same. In a visual assessment, a client presents with dark spots, uneven tone, what we consider to be hyperpigmentation. At the surface level, these dark spots look almost identical to other hyperpigmentation, but ask some questions and the story changes completely. Client A, for example, developed dark spots after acne cleared. This information now indicates post-inflammatory hyperpigmentation. Client B has dark spots that appeared gradually over 10 years in the sun. That history indicates solar lentigines instead. It's the same visual outcome, but completely different root cause, completely different driver, and this is why assessment is everything. Post-inflammatory pigmentation happens when inflammation triggers the POMC-MSH cascade. The trigger in this example is acne paired with picking, harsh treatment, inflammation of any kind, in fact. The mechanism is the inflammation that activates the pituitary. POMC is released, MSH signals melanocytes, and melanin is overproduced as part of the skin's inflammatory response. This means that the hyperpigmentation is the inflammation response. It will fade as inflammation resolves if everything else operates normally. The timeline is typically 3 to 6 months, sometimes longer if the trigger continues. The treatment angle here is to stop the inflammation, support the barrier, and let MSH signaling naturally decrease as inflammation decreases. Melanin fades because the cascade stops signaling. When might you consider corrective treatments? Only after inflammation is completely resolved, which takes weeks to months. It is a slow process. Now, solar lentigines are different. These are due to cumulative sun damage. The trigger is UV exposure over long periods of time. Repeated sun damage triggers melanocyte clusters to become hyperactive and dysregulated. The mechanism is chronic UV exposure that leads to oxidative damage, that leads to melanocytes shifting into overdrive. Pigmentation becomes entrenched. What this means is that the pigmentation is a structural change in the melanocyte's behavior, not an inflammatory response. It won't fade just from reducing inflammation. Here, the timeline is almost irrelevant. These lesions are persistent unless addressed, and they don't fade without intervention. The treatment angle is that you are working with a structural change, not a temporary inflammatory response. Barrier repair is still foundational, but you may need corrective measures to address the melanocyte dysfunction and the pigment as an end result. So here's the key difference in treatment. Post-inflammatory hyperpigmentation is from an MSH cascade that is activated, the melanin in response is produced, and this fades with time and barrier support. Solar lentigines, on the other hand, are structural melanocyte dysregulation that leads to persistent pigmentation. It requires a longer protocol and potentially corrective treatments. The assessment question that matters is how long have you had these spots? Now, recent spots appearing suddenly is more likely inflammatory, and you can expect them to fade with barrier repair and inflammation control. On the other hand, spots that have been there for years are likely structural sun damage and expect these to take longer and possibly corrective treatment consideration after barrier repair. Now, here's why scope of practice comes in, or where it comes in, I should say. As estheticians, we can assess pigmentation types. We can ask the right questions. We can determine if it's likely inflammatory or structural based on the history and the presentation of the lesions. What we cannot do is diagnose skin conditions. That's a medical diagnosis. We can, however, assess the pigmentation and recommend appropriate protocols based on that assessment. This distinction matters legally and clinically. Here's what an assessment looks like in practice. We want to ask how long the pigmentation has been present, ask if this appeared suddenly or gradually, observe if there's current inflammation, assess the barrier integrity, determine if this is likely inflammatory or sun-induced based on the story that the client tells you. Recommend the appropriate protocol, but do not say something like, I diagnose you with post-inflammatory hyperpigmentation. The first is an assessment and the second is diagnosis. One is in our scope and the other isn't. I actually wrote an article for Dermoscope magazine on this, and you can feel free to look it up. Now, the reason that we want to assess pigmentation and figure out what type of pigmentation it is we're dealing with is because different pigmentation types respond differently to barrier repair and cascade interruption. Post-inflammatory hyperpigmentation responds to barrier repair and inflammation control. So lentigines respond more slowly and may need those corrective treatments at a later date, but only after the barrier foundation is rebuilt. If you treat them with the same process, you're going to get very poor results. If you understand the difference, you get sustainable results. I hope you found this information helpful. If you did, please take a moment to like, comment, and subscribe. It means the world to me, and I will see you next week.